in some areas where maybe they don't see the pharmacist as often, they're usually quite surprised to see someone, and they're actually quite grateful. If anything, they have so many things they want to tell me about. They're always so excited to talk about their medications because they're interested that someone is really taking so much care or so much attention to really look into their meds that they're so used to taking.
Welcome to the Specialty Café, the podcast that helps you, medical trainees, find your perfect specialty. My name is Cameron Wong, and I'm a current fourth-year medical student at Queen's University. I'm really excited to be producing this episode as a part of the Prep for July 1st campaign for incoming fresh R1s. And in this series, we're hoping to chat with all the different allied health staff that collaborate with residents in the hospital and get to know what their roles are, how they fit into the medical team, and most importantly, how can residents learn from them as well. And so I'm really excited to be chatting with Mr. Clement Chan, who's a pharmacist at the Kingston General Hospital and a pharmacist that I collaborated with really closely when I was on my internal medicine rotation at the Kingston General Hospital. So yeah, very much looking forward to this episode about chatting about pharmacy and all of its wonders. And so yeah, thanks so much, Clement, for joining me. Really, really happy to be chatting with you.
Yeah, thanks for having me. Glad to be on.
Yeah, thanks so much. Before we get started, do you think you'd be able to introduce yourself?
Sure, absolutely. So my name's Clement, Clement Chan. So I'm a pharmacist at the Kingston General Hospital. I work largely inpatient internal medicine, largely. So largely I cover the medicine service. We do have a team-based approach, so sometimes we rotate through some different teams and cover different patients, but for the most part, we're pretty consistently on our team and on our floors. Before this, I've worked in a couple other hospitals prior to that, so my experience has been in inpatient medicine, but prior to that, I also worked in family health team in primary care, so I have a bit of experience kind of seeing that side of things from an ambulatory perspective, and then largely my education has really been at the University of Waterloo. So I did my undergrad and my pharmacy education there. I did some rotations kind of around the Ontario area, but for the most part, I've always stayed around the Toronto area and kind of Northern Ontario as well for some of my training.
Oh, wow, yeah. So you're an Ontarian through and through, it sounds like.
For sure, yeah.
Yeah. Before we get into the serious questions, I wanted to ask, as a pharmacist, you must have a favorite drug. Do you think you could tell me what it is and why?
Oh, definitely. So my favorite drug actually maybe isn't as interesting as some people's. I'm sure some people have like really interesting new drugs or really specialized drugs. Mine is actually pretty basic and has been around for a long time. So my favorite drug is nitrofurantoin. And it's actually not because it's anything special or anything, but it's actually just the way it looks. So I actually always liked it when I used to count it in a community pharmacy because it's got this really bright yellow and black capsule. So it was just really bright and really kind of flashy to me. So I always found it really interesting. And I always said it looks kind of like bees in a good way. Thankfully I'm not allergic or anything, but I always found it really cool. And I find even nowadays, like even though it's an older drug and whatnot, we still find a lot of good uses for it. So it's always kind of been my top pick for at least interesting drugs.
Is it one of the only drugs that comes in black and yellow?
I want to say probably it's the only one that comes to mind. There's some other ones that are probably even brighter colors, but there's not as many that are that color as far as I can think of.
The reason I ask is because, like, as a med student who rotated through a whole bunch of different services, emerge, internal medicine, as we work together on, patients will often ask me, like, oh, well, like, do you know what drug this is? And, like, describe, like, a red or blue pill. And I will never, ever know the answer just because I just don't know. But I would guess that, like, a black and yellow pill is pretty unique, like nitrofurantoin.
Yeah, it's definitely not one that you see all the time. And even for us, I think a lot of the times people ask us pills and things. And I think the idea is that people think they're like, oh yeah, you must also always see the drugs and whatnot. But actually in the hospital, we actually don't see the drugs quite as much. Everything's packaged so nicely in little like small doses. You actually don't end up getting to see the drugs a lot. So even sometimes when people ask us, we go to the wall, pick up the drug, look at it and go, oh yeah, that is this one. So even I don't always remember all the colors.
Yeah, that's very valid. So yeah, zooming back into the serious questions now, starting off with the first one. What is a pharmacist?
Well, that's always a good question. I guess a pharmacist, it's really pretty broad, and it really depends on kind of where we are. We always call ourselves the drug experts or kind of the medication experts for the most part. And I think for the most part we are, because we do work with a lot of different professionals and a lot of different healthcare providers across the spectrum. So whether it's people like you, like in their earlier stages as a clerk or a learner or a medical student, to people who are experts in their field, specialists, physicians or whatnot, and even amongst allied health and other people as well. So I think a lot of people encounter pharmacists as a whole. I think for the most part, people think of pharmacists as someone who works within a pharmacy, or they always think of like the retail side of things, where you see your big banner stores or shops and whatnot, and they think that's kind of where they're most likely to encounter the pharmacist. My side of things is maybe a little bit more behind the scenes. So for me, pharmacy and pharmacists, what we do is we review medication orders and make sure medications are appropriate and probably and best selected, I would say, for patients that come into the hospital. And from there, we try to look for ways to safely give the medications, monitor them, and try to optimize what we can or optimize what we can do with the medications to help the patients get better or improve their care overall. So for me, pharmacists are those experts that reside within the hospital, at least in my area. And you'll see the same thing for pharmacists that do kind of that same job, but just in different settings. So whether it's in a more community setting, or sometimes in even institutions and even in policy and making, we're all sort of involved in it, but just at different steps of the way with the medications.
If you asked me like what is a pharmacist when I was like back in first or second year when I hadn't had a lot of hospital exposure, I would have like said what you mentioned, which is that I would have thought like pharmacists are only found in like the retail setting at Shoppers Drug Mart where I get my own medications. But I think like for like the listeners listening to this, Clement gave like a very, very good explanation of like what a pharmacist does. But like I think like for me, what you did on my internal medicine rotation and like I think what pharmacists like do in general is just so important. I can't explain like how many times like I've just been so grateful to have you on the team when like I don't know like, oh, what is the dose of this antibiotic, or like how can I navigate this like really complex patient's diabetes medication, especially if like they have renal failure or they have other like strange things going on with like their physiology. So your job is very, very important for sure.
Yeah. I mean, we're often always scattered throughout the hospital too. So sometimes you'll see us in one area. Sometimes we're on the floors or on the wards. Sometimes we're rounding with you guys. And other times, sometimes we're in the pharmacy where we're actually verifying orders. Sometimes it's remote, and sometimes we're just there, kind of in a different room. But we're always around. I like to say.
Yeah, very always around when needed for sure. To kind of like clarify things for like listeners who haven't maybe been in a CTU environments, and CTU stands for the Clinical Teaching Unit. At least at the Kingston General Hospital, that's where many of the general internal medicine patients are admitted. So people who come and have a variety of different conditions that need care in the hospital: heart failure, arrhythmias, for example, infections of the lungs and of other organs as well. So many different types of patients. And so in that environment where there's like pretty medically complex patients, how would you describe how you apply your expertise to like help care for patients as they're in hospital?
Yeah. So I think a lot of the times is, especially with medicine, you do get a large variety of different patients, and you kind of never really know what you're going to get. Part of that I find for me is sort of the excitement. For me, I think because my training and because my work is I've worked in a variety of different areas kind of as the years have gone through. I'm a little bit more familiar, a little bit more comfortable with seeing those different states. A lot of it is actually stuff we often don't learn. So a lot of the times we rely a lot on even when I guess learners and whatnot go through teaching and stuff. We also learn a lot on the way as well. So I think when we approach those things, a lot of the times is when we come in, we usually, thankfully, there's usually people looking at their medications as time goes on. So usually we rely a lot on our colleagues as well, that they help us identify some of the issues. Oftentimes, when physicians have reviewed things, they've often identified some medication issues for us as well. So oftentimes, most of us kind of start by looking at the medications and we say, okay, so what are the medications that someone's on? How does that align with their medical conditions? So usually we kind of have this sort of matching sort of approach where we say, okay, so this drug is for this condition, this is for this, right? And usually that's kind of where we start to look and see what's what, so we're more familiar with what's actually going on, and to make sure that everything aligns and everything makes sense. Because then sometimes we come across some medications where we're not sure what it's for. And then we do a little bit more digging, and then we see if there's things we need to optimize, or maybe it's something that's inappropriate, or maybe just things that are a bit more rare, maybe that we haven't seen as much, or maybe there's a better option for it. So that's usually, I think, the approach we look at when there's a lot of different systems at play. We kind of break it down, we go drug by drug, and we go from there. That's usually our approach, I think, for most complex things.
Yeah, very systematic for sure.
Yeah, for the most
Yeah,
part.
and very much, I guess, like the way that I guess like I as a medical learner would look at things, just with a much different lens. When I like see a patient, oftentimes it's like the medical issues that like I'm going through, like in like system by system, thinking through like things from like a medicine standpoint, things I was taught during pre-clerkship and stuff. But really good that you have that other expertise with regards to drugs, and as well, I think like one particular expertise that like I'm really glad that you have, that I don't think I was taught as much in med school, is like your knowledge of like, you know, how a drug is metabolized, and like other practical considerations like that. Just because like when, for example, a patient is in renal failure, or they have like half of their small intestine missing, I would, as a medical student, I would just throw up my hands. But I think like you have a bit more expertise to be able to advise on that. So like very important that you're there for those CTU rounds.
Yeah, and I think our approach, it works. I think it works in tandem, and it often comes together quite nicely because we always say that physicians and that side, like you often approach it from a more pathophysiological standpoint, and then from there you kind of go through the disease state and kind of decide what the drug is. Whereas we're often taught to go backwards, so we look at it from the other side. So we start with the drug and we kind of move backwards that way. It's helpful to know both sides of it, but because we sort of go from another perspective that way and we kind of intersect in the middle, there's usually room, and there's just sort of a different perspective on how we look at those medications, and how we look at the condition. So you do actually see a different side of things, and that's why sometimes we catch some things that physicians don't, and physicians catch things that we don't. So it always works really well together, I think, when you combine the two approaches.
You answered a question that I think I was going to ask, which was like, how do you think like you look at a patient's chart differently than physicians might? And it's like interesting to hear that like you go like kind of like contralaterally as compared to like physicians do. Yeah, so and that, I think that explains a lot of why like I might be looking at a patient and thinking one thing, and then you'll have a solution that I think like honestly I think your your prescribing solutions are very elegant, like when it comes to making sure that like people are like covered for the antibiotics, or like making sure that like they're on like the right medications for their conditions. So yeah, very important.
Yeah, and I think we have a pretty systematic approach to it. I think pharmacists are probably inherently people that try to be very detail oriented and very systematic. So I think even when we go through something very simple, it can be any drug, and like something really complicated, or something as simple as could just be like electrolyte replacement, or even something like minor pain things like that. I think we always try to follow the same approach, where we really look and say like, is this the right medication? Is this going to work? Is this unsafe, or are there things I need to monitor for it? And then really like, is this something practical? Is it something that it means someone would have to take a handful of pills every day, or is it something that's multiple times a day? Because then we'll start looking for different options and whatnot, and trying to kind of weigh our options and to see what's best.
So I want to change gears a little bit and talk about the transition to residency, which is very applicable to me because I, alongside many other fourth-year medical students, will be residents in a short 2.5 months or so, 2 months, and I'll have prescribing power. I might not have been in the hospital for several weeks at that point. I don't think I'll be super confident in making sure that from like a prescribing side of things, like things are as safe as they can be, as like eloquent as they can be. So with that being said, what kind of like practical pieces of advice would you have for incoming R1s who are coming to a new hospital, maybe adjusting to a new system, and like in a way refreshing their like mind on clinical medicine from a pharmacy perspective?
Yeah, I think there can be a lot of challenges with it all, and I think it's easy to forget that everyone was really a learner at one point, whether it's the pharmacists that are doing it, or even the attendings, or other more experienced prescribers as well. So really the important thing for sure, I would say number one is to make sure you ask for help if you need, or really if you need some clarification. There's always someone around to help. Pharmacists obviously are around, and we're used to putting in some medication orders, or making changes and whatnot. So we'll have a pretty good sense of kind of how you might have to do things. And sometimes it's little nuances that you kind of know what you want to do, but you just can't really quite figure out how to put it into the system. Or there's details where you're like, I want A, B, and C, but I can only figure out A and B. Like, how do I do that last part? So really, I think asking for help with that is really helpful, because it's better for you to kind of have a bit of assistance and get it right the first time than to try to go back and do it. Because sometimes you'll have to just redo the whole thing. Or sometimes if you're not kind of sure where the steps are, it's harder to make those corrections in the future, where you might have a similar thing but not really the exact same kind of situation. So I think asking for help is really important, first of all, because we have like even more experienced prescribers that will ask us all the time for simple things as well, because sometimes they just want an extra set of eyes on things, or just a double check. And the other thing, because of that, I also will say is, don't worry too much about that, because despite kind of wanting to do everything perfectly or getting everything right, we are all human. We do ultimately make some mistakes, or maybe it's not exactly the right way to do things, but there's always someone to double check, and there's always someone to bounce ideas off of. Because even amongst pharmacists, sometimes we'll put in orders and someone else will look and say, hey, I think you might have done that wrong. And sometimes that does happen, right? So even amongst colleagues and whatnot, we often have a double check for that. In terms of the actual kind of, once you get into the system and you're putting things in, I think a lot of the times things that happen for pharmacists are things that we often find we're asking prescribers about, or double checking, or sometimes it is things like drug interactions. So obviously those things do come up. I think more often than not, some big things that often maybe not bother us, but maybe prompt us to kind of look a bit further, are often allergies. So those are things that we often care about. Sometimes it's, a lot of the times actually, it's probably allergies to different medications and antibiotics. Other times it may just be other classes of medications where we're just keeping an eye out. So that's probably one thing we always try to look for, and it's probably useful for physicians to keep an eye out for before they're prescribing any medications. Another thing is often duplications, where you're on one drug which is very similar to another, or maybe you're just thinking like, oh, I want to switch one thing, but you forgot that they had another similar medication in the profile, or similar thing that they're taking. So that's often another, I think, area that pharmacists try to reach out for and try to prevent, in terms of maybe errors, or just areas where it's maybe not as optimal. And then the last part probably is more so dosing. So I know it's quite hard, I think, for newer prescribers to try to remember all these doses. And even for us when we're starting, actually, even for us, dosing isn't really often emphasized as much as something that really we need to commit to memory. So oftentimes it's things that we're used to only by experience. So it's not to say that it's something that you don't necessarily know, because oftentimes we didn't know it earlier on either. So it's just, as time goes on, we pick these things up. So for us, I think people probably underestimate how often we check our resources. So even as someone that's practiced for many years, and even often for simple drugs, I'll still do a double check just to make sure I remembered it right, because I can't always rely on memory. So I almost always will double check doses on different references to make sure. Sometimes I have handy things that I've saved, or even just documents, maybe some from a hospital I've worked at or whatnot, that is my little reference point. So I'll keep a bit of a repository of different resources that I find useful for myself, so I can refer back to from time to time. So I think those major areas are probably what will best help newer prescribers in doing things. So kind of looking at allergies, double checking to see that the medications aren't all kind of stacking on, and they're all not all duplicating each other. And then also just checking the doses and making sure that those are appropriate for their patient, whether it's because their kidney function isn't as well, maybe they're older, or maybe it's a weight-based approach where things need to be changed. So I usually will always consult my references for those situations.
Right, right. I'm really glad that learners have you as a pharmacist on CTU, honestly, because I think like what you said, and like what really underlied what you said, was that you're patient with people who might be on their first ever internal medicine rotation, making orders on behalf of other people if like they're a clerk, or making orders for the first time if they're a new prescriber, like I will be in 2 months. So I think that's like really great advice, and especially to like ask for help when needed. I think that is like a really, really golden rule in medicine, just because it is so hard to know everything, and like I think unfair to ask people to know everything when they first start something and just to automatically be good at it. So it's a very real piece of advice for sure. You mentioned that like common first things that you tend to correct and advise on when people are starting out? And I'm sure like also at all points in the year are things like allergies, duplications of medications, and other drug-to-drug interactions. Alongside that, are there pieces of advice that you think you would give to like incoming residents that would like kind of help them like get like a really good head start? Like make sure you look at your patient's allergies, make sure you think about like drug interactions, kind of like concentrated pieces of advice like those.
I think the approach for the most part, I would say, is pretty similar to sort of how I mentioned before, where we often, even when we review orders, I would say that maybe that approach is sort of the best way to start it. So if we're looking at orders, or I guess from my perspective, when I'm looking at a new order, the first thing we do oftentimes is we check allergies to make sure that the patient's not just blatantly allergic, or maybe that there's just something that is similar, but maybe we just need to look a little bit further into. And then beyond that, usually the next step we look is to make sure that the dosing is first of all appropriate for like a normal person, or like for a normal kind of situation. And then from there, if it is, or maybe if it's say a little too high, a little too low, then we start looking and say, are there any kind of patient specific factors or sort of specific reasons why this might be it. Sometimes it's a lot of troubleshooting or a lot of kind of sleuthing or kind of detective work on our part, because despite all of us being in the same system, we're not always on the same page in that we don't always know what's going on right at that same time. It's helpful when we're kind of next to each other and we're putting in orders, but sometimes we're a couple steps behind, or sometimes we're a little bit later to when we see the order, so we often have to do a little bit of detective work. But from there, we usually look and see, are there things that might necessitate a higher dose, lower dose? So things like that are often things like I've mentioned, like a different dosing weight, or things like a renal function, or just changes in their kidney function. So whether there's something acute that's meaning that they don't clear the drug as well, so maybe they need a bit less, or some other things where maybe they're on different modes like dialysis, or things where the dosing is quite different, or maybe the timing is really important among some of those things. So those little nuances we'll try to fit into the medications. And then we also look and say, sometimes, is this medication something that's going to be ongoing, or something that we need to think about or reassess at a later date? Is it a few days? Is it tomorrow? Or is it maybe just a month or two from now? So for those things, we often flag ourselves and say, are there follow-up things we need to do? And then oftentimes from there, we really just identify those things and kind of add it to our list of tasks and lists of follow-up issues for ourselves. And that kind of works itself into our workflow.
I think what I wanted to pluck out of what you just mentioned was that it's a big emphasis of yours to ensure that like medications are followed up on, especially if you start them for a reason and like you want to reassess later on, just because I think like when the list gets really long and there's a lot of patients to see, sometimes like the plans can get short-sighted just because there's a lot of cognitive demand for like people who are managing it. So I think it's like really good that like it's really, really helpful to have a pharmacist on the team to be like, well, they've been on antibiotics for a very long time. Like, should we reassess this? Or like, do they still need to be getting like potassium replacements? Like, because they're no longer hypokalemic and we might be making them hyperkalemic. Really, really important things like that. So we've chatted a little bit about practical tips that you have for incoming residents. One thing I wanted to clarify briefly that is also helpful for younger year medical students as well as residents is to clarify, do pharmacists see patients as well? And what will you chat about when you see a patient, if you do?
Yeah, so we often do see patients. I would usually say it's typically at the start of their hospital admission, kind of when they come in, and sometimes at the end of it, depending on what their needs are. Usually, when we see patients, they're often unfortunately confused that they think that we're from the pharmacy they usually go to, and I often have to say, no, like I don't work at the pharmacy you're used to going to, but I actually work at the hospital. So that's often kind of an area that kind of surprises people, because they often don't realize that the pharmacists are around in the hospital. But usually when we're looking at, or when we're seeing patients and meeting them for the first time, often what we're doing is we're collecting medication history and trying to make sure that we have a good sense of what the patient is coming, or what they're coming in from home, like what medications they're on, what medications they're taking. And sometimes sometimes we're able to approach it from a little bit of an easier lens because it's in kind of the light of day. Things aren't overnight, so more people are there. Sometimes family members are there to help us. So we try to kind of tease out a little bit more information and try to get a more comprehensive look at their medications. So we know kind of what medications are there, sometimes things that are over the counter or supplements that they don't always see. So those are often things that when we're talking to patients and when we're seeing patients, those are what we're often asking, at least at the start. Later on in their hospital admission or in other settings as well, sometimes it's for things like follow-up. In the hospital setting for me, I probably see patients a little less from that perspective. Um, Usually I would say probably residents and clerics and physicians are seeing them a little bit more throughout their hospital stay. Sometimes in an out of hospital setting, you might see pharmacists visiting patients or kind of following up with them on certain chronic medications where maybe they're making some adjustments or some allied health or other providers have asked for the pharmacist maybe to do a bit of follow-up, whether that's something like checking their blood pressure or maybe checking blood sugars or things like that. In our setting, this isn't something I'm involved with too much. But sometimes on the other end of discharge or where patients are nearing the point of discharge where they can go home or to another facility, then sometimes what patients will benefit from usually is a bit of counseling in terms of some of the medications that have changed. So whether that's things like new medications we've started or things maybe where we've changed it or even things that have been stopped because sometimes they're just so used to those medications that they're not familiar with it, or new things that they're just simply not familiar with. So usually we'll go in and we'll sometimes talk with them and kind of explain what the new changes are, what the new regimen might look like, things like that. So usually it's kind of a meet and greet is what I kind of call it from the start point, and then usually the counseling piece is what we're usually most involved with when we see patients face to face.
I did not know that patients would mistake you for being from like their like native pharmacy almost. Do you like also get that for patients who like come from real like far away from Kingston?
Yeah, I would say that for the most part, it's I think and it's really no fault for patients. It's because the majority of pharmacists truly do work in retail settings and whatnot. The vast majority of pharmacists that you're going to see often are in those settings. So that's where you kind of get the most contact with people. So that's kind of what I think people associate most pharmacists with. But in some areas where maybe they don't see the pharmacist as often, they're usually quite surprised to see someone, and they're actually quite grateful. If anything, they have so many things they want to tell me about. They're always so excited to talk about their medications because they're interested that someone is really taking so much care or so much attention to really look into their meds that they're so used to taking.
That is another aspect that I'm really grateful to have like pharmacists like you in collaborating on like really complex patients because like patients are on so many different medications, especially like with the aging population and like the advent of many new different like wonder drugs kind of means that like many people are on them.
Yeah.
And so I'm really glad that like you personally take that time to go through in a detailed fashion through each of the medications and clarify them with patients and make sure they understand what they're on and like why they're on it. Yeah, that's really good. Another question I have is if a resident, for example, was pressed for time and they only had like 10 seconds to consult a resource for like drug dosing and like drug indications, contraindications, what resource would you recommend?
I think our approach is actually probably fairly similar to what most physicians would instinctively reach for. So we also use UpToDate, but more so from the LexiComp side of things. So LexiComp is the sort of built-in database part within UpToDate. It looks at the drug, the medication details, resources, things like that. So I think if we're kind of looking at a fast approach, that's usually where I start. It's a fairly stepwise approach, I would say. I usually go first of all to look at the actual overall dosing. Then I look and see in cases of, say, kidney adjustment, hepatic adjustment, or liver adjustment, are there specific dosing considerations I need to think about for that drug? So then I look at those pieces. And then from there, sometimes if there are, or if maybe things are a little unclear, then I go a little bit further and I look at the interactions that are listed there, or some major interactions that might be useful to know. And usually from there, that same area, there's some contraindications. And then maybe with the more pharmacist side of things for us, we're often looking more so at the drug itself, right, and how that affects the body and how the body clears it. So then we actually often look at the pharmacokinetics just for a little bit more details in terms of what that looks like. How long is that drug going to take to get into the system? How long do we expect for things to kind of reach a kind of steady kind of predictable state? So usually I start with looking at the dosing, and then I look and see if there's any areas I need to tweak it.
It's good to hear that you also use UpToDate. And I have heard of LexiComp. It's the side of UpToDate that I don't use, just because I mostly just default to using like the regular side of like the
Yeah, so
pathophysiology
when you're
side.
searching the drug, it's
Yeah.
essentially built in. So we are actually largely looking at the same thing, which is usually
Oh,
helpful. And then sometimes we often have our own resources, or sometimes we use a different program like Micromedics, or there's a couple other ones out there. And certain institutions might have their own guides in terms of antibiotic dosing, maybe some renal dosing for some other drugs. So usually we'll cycle through a couple different ones. I think our teaching usually, or our concepts usually, is what we say is we try to look for one. If we can't find it, or if there's a little bit unclear, then we look for another one. Which is probably a good approach to just to get a bit of variety and just to get a bit of a range to say, on one end, if I were really conservative, I could go this way, and on a more aggressive end, I could go the other way. And then usually at that point, I'll look and pick something in between on either end.
yeah, that's very valid. But like surprising actually that we use the same thing, but and also like very reassuring. Just so it dispel the myth from my mind that like you guys have like a secret Bible of drugs that you refer to, and I've been missing out on something. But yeah,
No,
it's
and I think a lot of the times we just tend to keep a lot of things as resources, and I think we just keep a lot of notes. I think as time goes on, so oftentimes different hospitals or different areas, we have drug information specific pharmacists who often will have a lot of these questions come up, or things that maybe people have asked before. They've had these questions in the past. So sometimes the reason why you can't find them is just not because you haven't been looking. It's just that someone's just been looking for it already, and has already kind of gathered all this information already. So we're just so quick to it because someone's already done the work for us, thankfully. It's usually one of our colleagues or whatnot. So we often keep like a big bank of different questions, or situations that have come up, and that's why we're able to refer to it as well.
Oh, that's very cool. So I guess in a way there is a secret Bible of drug
In a
information,
way,
but it's
yeah.
just the one that you've already created with the help of your colleagues.
Yeah.
My last question for you kind of flips the scripts a bit. We've been talking a lot about how like pharmacy contributes to like a patient that is particularly complex, like admitted to internal medicine as like your focus is. But like to kind of like flip the scripts, what are some of the ways that you found that residents can help you do your job most effectively?
I think the way that you guys approach the different patient cases, and the different diagnoses and those problems is, like we've kind of mentioned before, is a bit of a different perspective than how we look at it. So it's helpful because sometimes you'll identify problems that we haven't even considered, or maybe we're so fixated on certain drugs that we actually sometimes forget, or maybe don't focus on some of the bigger issues at hand. It's both useful sometimes, and sometimes may kind of tend to miss some of the parts of care as well. So that's why it's helpful, I think, for you to provide that perspective. We're often not as good at looking at those conditions and kind of arriving at those conclusions. So we rely a lot on physicians to kind of make or identify the problems for us, so that we can try to help and, I guess, look for some of the solutions or some of the medication changes at that point. But in terms of, I guess, how we would approach those things, I think we find it very helpful that you're able to identify those, because we're able to then stratify some of the problems and see what we need to follow up on. Because for us, we often end up seeing a lot of patients, or we have a lot of patients kind of under our care. So it's not always possible for us to look at every single person. So we rely a lot on other providers, whether it's allied health sometimes, where we hear certain things, maybe difficulties with certain medication administrations, or just changes in their care where we might need to make some tweaks. So we actually rely a lot on other people to kind of let us know about some of the problems, or things where we might need to change or kind of optimize some of those medications. Because otherwise, I think on our own, we often can't get to all of those things. So I feel like a lot of it is actually relying on others as well to take
Huh.
take note of those things.
Yeah, yeah. I mean, that kind of, well, challenges my notion of like you as a pharmacist and like pharmacists in general, because I think like with the amounts of work you do with collecting a best past medical medication history and like making sure that like you're on top of all the different like medication changes that are going on, I just like have it in my mind that you have like some superpower to be able to like process 50 different patients at a time and like know exactly what to do. But I think it's like it's humanizing in a way to just know that like you also like you're focused on one part of things, and in a bit of a two-way conversation, like you're relying on the med students and the residents to like gather like big picture things about like the different conditions that are at play and like and things from like a medicine perspective that way. So
Yeah, and I think even sometimes it depends on the workload because some days it can be really hectic. So even amongst ourselves, we rely on sometimes other pharmacists that have caught some orders, that have been processing some orders that are like, hey, we noticed this thing, so maybe you want to follow up on it. What's especially useful sometimes is that we have colleagues that are trained well in other areas. So although I might be more familiar with some medicine concepts, sometimes someone from cardiology or maybe someone with an ICU background sometimes looks at the orders and says, hey, like I noticed this person was on this, but it also provides a bit of perspective for us as well. So it's helpful sometimes to break down my workflow because otherwise I think it's hard for us to kind of know a bit of everything. We rely on the expertise of others as well.
And no one can know everything for sure. And I think that's like especially important in general internal medicine as your expertise is. There's just so much to know, but I feel that like you do know a lot and it's very, very apparent in your work as a pharmacist. So yeah, for sure. Well, I was really, really glad to get the chance to chat with you, Clement. I've been like looking forward to recording this episode for quite a long time, just because I have very good memories from like our rotation on internal medicine together, and I would really, really love the chance to kind of like refresh myself on like what would a pharmacist know that I can bring forward to when I start my residency soon. So very helpful. Thanks so much, Clement.
No, absolutely. We always appreciate learners, and like we said, we're always learning through it as well. When you guys go through the learning, or when you guys go through teaching, and when we have the opportunity also to provide what we know and kind of for us to teach, we always appreciate it because it's always a good opportunity to collaborate and for us to be kind of part of the team as well.
Thanks so much. Yeah. Well, I guess that wraps up this episode about pharmacy with Mr. Clement Chan, a very, very excellent pharmacist at the Kingston General Hospital. Was very happy to learn the advice that he had for me as an incoming resident and for all the other incoming residents as well listening to this episode. So yeah, please make sure to listen to the other R1 prep episodes that we have. Lots of other excellent episodes with the other allied health staff, nursing, spiritual health, and patient care navigators as well. All really, really important people that helped a patient get the best care in the hospital possible. So yeah, thanks so much, and I'll see you next time. This is Cameron Wong with the Specialty Café.